The title of my talk was Cancer Groundshot, Going Global Before Going to the Moon. So this was in reference to the Cancer Moonshot projects that have been so much popularized in scientific community as well as in lay media. So Cancer Moonshot project, I was not here to criticize the Cancer Moonshot project, but the focus of my message was if we spent even a fraction of that money on Cancer Groundshot, then we could be saving more lives. And what Cancer Groundshot actually meant was things that we already know, things that we know that work, and things that are applicable to people living across the world, irrespective of their purchasing power, their income. So for example, this includes things like prevention. For example, in case of cervical cancer, this was one topic that I talked in detail. Cervical cancer is a cancer that we can actually prevent. We know that HPV vaccination helps prevent cervical cancer. We also know that there are effective strategies to screen cervical cancer so that we can detect them earlier and cure them. But still, there are a lot of countries in the world where a lot of women die of cervical cancer, and this actually 85% of the cervical cancer mortality burden is in low and middle income countries. So this is unacceptable. While we are talking about cancer moonshots and immunotherapies and precision medicine that are supposed to improve survival by a couple of months, we know that cervical cancer is preventable and we can cure it, but still we don't have funds to implement and educate people living across the world about this strategy, and we still see women dying of cervical cancer. So this is unacceptable, and so that was my focus of talk. And not only prevention, there are other things that we can do. For example, co-development, where high-income countries and low-income countries work together to find appropriate strategies, cheaper strategies that can be applicable globally immediately, and more cancer patients will benefit from that. One such example is the use of technology, for example, the web-based application to report patient-reported outcomes, which improve survival significantly. So instead of focusing on this type of approaches that are applicable everywhere globally and at a low cost, we tend to focus on these big overhyped projects and spend a lot of money on that, and everybody is spending money on that. So the problem is, for example, immunotherapy is receiving funds from everywhere. Every government is funding that, every billionaire is funding that, but nobody is going to fund implementation of HPV vaccine in Kenya or in Nepal. So that was my main message in today's talk. And I also gave another example from drug repurposing. So drug repurposing is the use of cheaper drugs that are already approved for other indications, and we try to test them whether they are efficacious in cancer. One good example is, for example, the use of propranolol for angiosarcoma. There is some nice evidence that it could be effective, but we need to conduct proper big phase 3 RCTs to test these strategies. But the problem is, who is going to fund the trials of propranolol or the trials of cimetidine or statin, for that matter, because these are the drugs that won't give you good financial reward. So there is a lack of interest from the pharmaceutical company. But if we find an evidence that, let's say, propranolol or cimetidine or metformin or any of these cheap drugs are really efficacious in some cancer, then this is applicable throughout the world easily. Every person can have access to it, compared to showing that ipilimumab is efficacious in small cell lung cancer. Then nobody in Africa or nobody in my country is able to afford that. So this sort of discrepancies is what I focused about in my talk today. My talk was more about medical oncology. I didn't focus on those aspects, but other speakers highlighted those issues very well. And one particularly impressive talk for me was when they presented about how they used the internet-based technologies and smartphone-based applications to conduct an online training course for pathologists in Africa from UK, and without any funding. And this substantially improved the quality of pathological services in Africa. So this is an example of Cancer Groundshot project. So you don't need a lot of funds for that. They did it without any funding. And these are the things that actually matter to those patients, and these are the things that will actually improve outcomes. And as you said, and as Professor Wild said, like, instead of making a bigger cake, we are all trying to grab pieces of the same cake. So we are competing among ourselves for surgery versus radiotherapy or pathology and medical oncology, instead of making a bigger cake. Yeah, as you said, we are trying to, we are powering down money on the top, and we are hoping that some of it will trickle down to what actually matters. But we need to be maybe doing the other way around. We oncologists have that social responsibility to take steps in this matter, and to be proactive, and not confine ourselves to only those patients that are in front of our eyes in our clinic, but there are many other patients globally who need our help, and we need to be advocates for them. If not we, then who will do that? So as we discussed in our panel discussion, to give example of that pathology training, the speaker said that they actually are lacking funds to train those pathologists by bringing them to UK for a week's training, hands-on training, and they don't have money to do that. But we have so many instances in which we are giving off-label expensive chemotherapies or immunotherapies for many patients. So if we can avoid this off-label or ineffective or harmful use of one expensive drug for 1 year, then that could fund 5 or 10 pathologists to come to a high-income country and get training and go back and make use of that training in their own setting. So there are avenues which we can work together, and which don't require a lot of money, but needs strategy and innovative ideas. And we need to be collaborating together. So high-income countries, this is not a case of high-income countries teaching one way to low and middle-income countries. It's a two-way collaboration. There are so many things that a high-income country can learn from a low and middle-income country, and vice versa. And there are also things that we can work together so that it fits our common goal. There is a very nice example of the use of arsenic trioxide in case of M3 acute myeloid leukemia. So this is an evidence coming from a low and middle income country, but this is the standard of treatment even for high income countries. So it's not that low and middle income countries are waiting for high income countries to do something for them. The environmental context, the cultural context is different between low and middle income countries versus high income countries. So low and middle income countries are working to create better outcomes for the patients in their own way. As in the presentation of Dr. Sailesh, he showed that they are in India, in Tata Cancer Center, they have been working on pancreatic cancer surgeries, and they have improved outcomes substantially comparable to that of high income countries, but the setting is different. So low and middle income countries should focus on their agenda rather than trying to copy paste what high income countries are doing. And high income countries should also not think of low and middle income countries as a one-way preaching job, but a matter of learning together, developing together, and addressing common agenda. I think there are benefits for both low and middle income countries as well as high income countries with this common co-development project. Many patients lack access to these expensive drugs, and we have data that shows that many patients living in high-income countries such as US or UK, they are suffering financial toxicity as a result of the high expense of these drugs. And there is also data showing that these expensive drugs, they don't improve survival that much. But if you compare that with the groundshot projects that we are talking about, for example, training physicians or surgeons in low and middle income countries, building radiotherapy machine, there was an excellent talk after my talk by Dr. Peter about the use of radiotherapy in low and middle income countries. And he saw that with the use of the same amount of money for the chemotherapy, I forgot the exact figure, but he saw that we could develop a lot of radiotherapy machines in low and middle income countries, and that would be saving more lives. But what we need to be clear is we are not competing medical oncology versus other groundshot measures. What we need to be sure of is, first we need to make sure that basic level of services are available to everyone before we are trying to achieve marginal 1 or 2 months of survival gain. So without ensuring that every person has an access to basic health care, to basic cancer care services, if we are trying to invest the same amount of money so that 5% of patients can live for 2 months longer, then that does not make much sense to me. And the other important point is, when we are talking about Moonshot, such type of programs, we need to, we need to see if they have actually delivered the success that they are trying to achieve. And in my presentation, I showed that immunotherapies and precision medicine, some of the important strategies under the Moonshot, they haven't delivered success as much as we had hoped for. Still, there is time. Maybe they will in future. But what we have seen now is the success we have seen is very marginal. But compare, and even that success will be available to only a few patients who can afford that treatment, even in high-income countries. We are not talking about low and middle-income countries. People living in high-income countries do not have access to those drugs, and those who have access, most of them suffer financial toxicity, and we have data that show that financial toxicity in itself can impact survival. Now comparing that with, for example, vaccination coverage, availability of surgical expertise, or availability of radiotherapy services is completely different, because now we are talking about things that are used for curing cancer, not for incremental gains in survival, but for curing cancer, for early stage of cancer. If you don't have surgery, even stage 1 breast cancer can kill you by progressing. But if you have stage 4 breast cancer, then you are only talking about improving your survival by a number of months. So we have opportunities to cure cancer, so that should be our first priority, then adding 2 or 3 months of survival. Adding 2 or 3 months of survival is important. I'm not neglecting that. I'm not trying to disparage that. But at the expense of someone who can be cured of cancer is a different equation, and we need to be very careful about that.